Okay, can everyone see it okay?
Yep, it looks good to me.
Awesome. Well, Lee and I are really excited to be part of the Journal Club this week. Our first, we have the first paper, which was officially a randomized trial of prenatal versus postnatal repair of myelomeningocele, but more colloquially, I think known as the MOMS trial. I've heard people mention it as, so I think it was a really good one to start with because it lays a lot of the foundation for some of the more modern work that we'll talk about. So I think Leah's going to start us off with some of the background.
Yes. So just a little bit of background on spina bifida. You have spina bifida occulta, and that's characterized by a failure of one or more of the vertebral arches to meet and fuse. The spinal cord and meninges are unharmed and they remain within the spinal canal. And there's a bony defect that's usually covered with skin. Well, it is covered with skin, but it can be marked by a dimple, pigmentation, or a patch of hair. And then you have the meningocele, and this involves protrusion of the meninges and CSF into this cystic sac. The spinal cord remains within the vertebral column, but again, there can be abnormalities. And then the myelomeningocele is the most common and also the more severe one. And this has both spinal cord and meninges protruding into the CSF filled sac. And within the sac, the spinal cord and the associated neural tissue usually show extensive abnormalities. And damage to the spinal cord and peripheral nerves is usually present at birth, and this can result in irreversible damage despite early postnatal surgical repair. So kids can have lifelong disability, including paralysis and bowel and bladder dysfunction. And the myelomeningocele is highly associated with this Arnold-Chiari-2 malformation, and that is a congenital malformation of the posterior fossa, characterized by descent of the brainstem and cerebral tonsils and vermis through the foramen magnum. And animal studies have shown that prenatal coverage of these spina bifida-like lesions preserve neurologic function. And also studies with sequential ultrasound images of fetuses with these myelomeningocele suggest that the central and peripheral nervous system damage is progressive. And so this led to this two-hit hypothesis, which hypothesizes that the final neurological deficit results from a combination of failure of the neural tube formation and spinal cord injury, resulting from prolonged exposure of neural elements to the intrauterine environment. Next, okay. And so from that hypothesis, they started doing these prenatal myelomeningocele repairs. The first one was done in 1997. And early data suggested that there was this dramatic improvement in hindbrain herniation compared to the historic control. So that's the Chiari-2 malformation. And it also showed an increased risk of preterm labor, uterine dehiscence, and fetal neonatal birth and death. So this study kind of wanted to investigate that further.
So yeah, just to introduce a bit more of the actual trial to you guys. Like Leah mentioned, the prenatal repair had started to become a little bit more common and there was increasing interest in it. And so there were a number of centers that had started to do them, but there was no kind of centralized primary data aggregated to really show whether there was significant benefit or not. And so kind of as a community, there was a decision to do this official randomized clinical trial and limit that where these actual procedures could be done to 3 main centers. And so it was decided that it would be Vanderbilt, CHOP, and UCSF where these would be done. So if there was a patient that was interested in participating or having any sort of prenatal closure, they needed to go to one of these centers. And then as soon as they were officially part of the study, they were randomized still as to whether to go prenatal or postnatal surgery. And of note, also, there was a kind of a standardized procedure no matter which arm they were in. So they were all delivered by C-section at 37 weeks. And there was a certain protocol for if they were in the prenatal group, they had to stay in the hospital for a certain amount of time to be monitored. So there was a lot of standardization just in terms of the care of the moms as well. And then, like happens with many clinical trials, there were interim analyses done to kind of monitor as they were collecting data, how things were going. And I'll talk a little bit more about the primary and secondary outcomes, but they, just to kind of spoiler alert, they did 4 interim analyses. And the big takeaway for the study is that there was the Data and Safety Monitoring Committee at the last interim analysis concluded that they needed to end the trial for efficacy because there was such a significant result already that there was benefits to prenatal closure. And so they had kind of powered the study to have 200 patients, but at an accrual of only 183 is when they concluded the study. And just a few more things to note, they did have pretty strict inclusion and exclusion criteria. So inclusion criteria were things like not having twins or multiple pregnancies, just one singleton pregnancy. The myelomeningocele had to be within certain levels of the spinal cord. And then there had to be, so some of these overlap, normal karyotype and no other fetal anomalies for exclusion criteria, and they had to be within a certain age range. And those are the main ones. And for exclusion, basically they were trying to eliminate any confounding factors that would be risk factors themselves for some of the outcomes they were measuring. So fetal anomalies, kyphosis, other things that would cause risk of preterm birth, and maternal BMI. And just interesting to note, we'll talk more about this later, but some of the, obviously the results because of the exclusion criteria can't be extrapolated to some of these groups, but there are patients that are carrying fetuses that are interested in this sort of procedure. So there's been some debate in the field as to kind of trying to collect more data on those groups or whether they can expand some of the conclusions to those populations. And so to talk more about the primary and secondary outcomes were fetal or neonatal death, which fortunately there were none, but that was obviously their primary concern in doing the trial. And one of the really important ones was a need for a CSF shunt, because that is one of the main sequelae of the condition, and no matter the prenatal or postnatal closure. So they were really looking out for that. And that is one of the areas they saw a lot of benefit in. And then a composite score of several different measures that were kind of measuring function and psychomotor function and things like that. And secondary outcomes, they were looking for any other kind of surgical or pregnancy complications from the procedure, neonatal morbidity, and things like locomotion, functional impairment, and they kind of subtyped each of those, we'll see in the data. And then also, as Leah had mentioned, there's a strong link between some of the myelomeningocele patients and Chiari-2 malformations. And so they were looking at several different measures of the Chiari-2 presentation. And so in the follow-up, each of the babies they had MRIs reviewed by independent radiologists. And so just to give you some context here, they were looking at several things like the degree of hindbrain herniation. So you can see here a normal MRI, an example of a actually post-prenatal repair myelomeningocele child. And there's some hindbrain herniation here you can see below the level of the foramen magnum. And then they also were looking at the location of the fourth ventricle. So that could be compressed or in a slightly different anatomical location because of the mass effect. And then they were also looking here for this kind of brainstem kinking that can sometimes be seen. So those were the measurements they were taking for that. And then just a few more notes about the actual enrollment in the study population. So the main takeaway here is just that they were very careful to kind of look at the demographics of each arm of the study, the prenatal surgery and the postnatal surgery, and they were very comparable and similar. There were some slight differences in the gender of the fetuses and things like that, but nothing that would impact the results they thought. And here, like I had mentioned, there was a very strict protocol for kind of keeping the moms in the hospital for a certain amount of time during the surgery. And also, even though they were randomized to one arm or the other, the patients obviously still had autonomy in their choice of which procedure they wanted. So this is just showing in order to get to the actual 183 that were part of the study, some were excluded that kind of chose a different procedure, had to leave the hospital early, or had kind of other events happen that excluded them.
And then maternal and fetal outcomes. So there were no maternal deaths in either group. The pregnancy complications were more common in the prenatal surgery group, which I don't think is too surprising. The main complications were oligohydramnios, chorionic separation, placental abruption, and spontaneous membrane rupture. The main fetal risks were early birth. So fetuses in the prenatal surgery group were born at an average gestational age of 34.1 weeks, and 13% were delivered before 30 weeks. And this is compared to an average gestational age of 37.3 weeks in the postnatal surgery group, and none of the babies in that group were delivered before 30 weeks. And then there were also significantly lower birth weights and more cases of RDS or respiratory distress syndrome in the prenatal surgery group. And then there were, just of note, 2 perinatal deaths that occurred in each group. In the prenatal surgery group, there was an intrauterine death, which is a stillbirth, was diagnosed at 26 weeks, and then a neonatal death due to prematurity was diagnosed at 23 weeks. And both of these occurred on the 5th day post-op. And then in the postnatal surgery group, the 2 neonates with severe symptoms of Chiari-2 malformation and who had received shunts died.
So then the next, that was kind of immediately looking antepartum and post-surgery that Leah was just talking about. And then the next important time point that all of the participants were evaluated was at 12 months. And so these are the 12-month infant outcomes. And this is the kind of first really important outcome of the study. So you can see here on a lot of the measures they were looking at for a primary outcome that we've already mentioned. So whether there was a shunt placed, and then like I was referencing before, if there's any hindbrain herniation, and then how severe the hindbrain herniation is, if there's any brainstem kinking and how severe that is, location of fourth ventricle, and then other things such as cysts and syringomyelia and things like that. And so you can see here the p-values are pretty clear that there's a significant improvement in all of these in the prenatal surgery group. And so most notably kind of these, a lot of the functional things too, they were hypothesizing that it was due to some of this kind of anatomical improvement of these Chiari-2 factors. So things like obviously not needing a shunt will long-term for these kids have a lot of benefit because there are a lot of complications with shunts. And then having less hindbrain herniation and brainstem kinking can also correlate with functional things as well. And so I'll share some things in the discussion portion about kind of how this trial has impacted neurosurgeons' opinions in providing this procedure, and kind of these specific things that were shown to really be improved in the prenatal group versus the postnatal group are cited even today as major factors in people offering this procedure and recommending it.
And at 30 months, the secondary primary outcome, which was the score derived from the mental development index and the difference between the functional and anatomical level of the lesion, was significantly better in the prenatal surgery group than in the postnatal group. And this difference was primarily due to various motor functions. The prenatal group had better mobility, locomotion, object manipulation, and motor function. And notably, there were no differences in cognitive development. There were 2 deaths in each group between 12 months and 30 months of age. The death in the prenatal group was from Kawasaki septicemia, and in the postnatal group, it was from complications of chemotherapy for choroid plexus carcinoma.
So those were the main conclusions and takeaway data, not a ton to go through, but some really powerful conclusions, I think. So just to kind of talk about that further. So as we discussed, definitely showed definitive benefit, and it was, I think, a big impact in the pediatric neurosurgery field in terms of once the trial was concluded as well, it kind of that restriction to the procedure only being done at those 3 centers was obviously lifted, and there were a huge expansion of maternal fetal programs at different institutions, and kind of the Vanderbilt, CHOP, and UCSF that had developed expertise during this trial, trained other institutions, and the availability of the procedure really expanded. So it became much more widespread, but obviously it's still not the standard of care. So the decision, like for some of the participants in the trial, they even decided they did not want the arm they were randomized to, is ultimately still very personal and patient dependent. One of the biggest things, even though there was definitive advantage to the baby that was discovered, there was still significant risk for the mom. And so that's something to consider as well. And every family considers that differently. And then also another important factor is just cost and accessibility, even though I did mention that the procedure kind of expanded after this trial, that obviously is still not available everywhere. And even if it is at a closed center, a family might not have access to that care or ability to participate. And then I thought this was interesting. There was a study, and this is the one in the graph listed, or this table listed here, that was looking at parental stress in families. So instead of kind of like functional and anatomical and clinical outcomes, obviously having spina bifida in any form can have a big impact on a family and just long-term care. And so this was looking at kind of overall family stress measures using different scores in prenatal versus postnatal groups. And there was found to have more of a negative impact in the postnatal surgical groups, which is interesting. And you can kind of hypothesize that that's probably due to, if there is more functional impairment, that puts a higher strain on the caretaker. And so it was mostly here, they used a few different measures, but the familial and social impact was the one that was significant for improvement in prenatal closure. So that's another thing to consider. And like I had mentioned, since there is still significant risk to the mother, that kind of led to even more recent development of fetoscopic repair, which is featured over here. And we had a great talk by Dr. Bowman last week, kind of mentioning some of her development of that and some of the pros and cons of that procedure. So I think in terms of post-MOMS trial advancements, that's a huge one, because you're looking to get the benefit for the child of prenatal closure while still reducing the risk that poses to the mom. And since this trial was now 10-ish years ago, there's still a lot of ongoing data being published and kind of about the post-MOMS experience. So at both the centers where it was originally performed and the ones that have started to perform the procedure since then, kind of reanalyzing the data and looking even longer term. And the initial findings have really held true, but kind of some of the nuances of each ones are still being considered and debated in the field. And so just one more study that I thought was interesting. There was also a more recent study in JNS that was surveying just kind of neurosurgical opinions and perspectives on prenatal myelomeningocele repair. And there were some interesting stats in there that I thought I would share. So they surveyed a pretty good amount of respondents, 446 from around the world, but the highest level was in the US that they heard back from. And the average number, and so this was of physicians that provided the procedure, there was an average of 9.6 defects repaired per year. So interesting, I'm sure there are some experts and centers that do many, many more, but kind of getting enough cases to practice on is a factor to consider as well. And so of the people that responded, 91% provided open repair to their patients as part of their practice. Only 13 provided open fetal repair, and only 5% provided fetoscopic repair. So these two, the 13 and 5% being prenatal closures. So it's still, even though it's much increased since the MOMS trial, it's still relatively niche procedure. And some of the most common reasons for hesitancy for the providers that did not provide prenatal closure were things like I mentioned, lack of cases available to become proficient and risk of maternal complications as well. But then again, some of the advantages that people cited were, like we kind of mentioned, similar to the trial, decreased shunt dependency, decreased hindbrain herniation, and better motor function overall for their patients. And so I think the very interesting takeaway was only 17% of the respondents agreed that prenatal closure should be standard of care. So like I had mentioned, even though this trial showed really significant benefit and very interesting findings, it's not standard of care and it's still a very risky procedure. And kind of that's, I would think, a really complex discussion to have with patients. So knowing that there's a minority of neurosurgeons that believe it should be standard of care is an interesting statistic. And the last thing I want to share was, I'm sure a lot of you guys have already heard of the book or read it, but an awesome pediatric neurosurgeon, Dr. Wellens at Vanderbilt, recently wrote a book kind of about his experience. And since Vanderbilt was one of the original centers that provided this procedure, I think he was intimately involved in their program after the MOMS trial, but when it was still really involved with kind of providing the procedure for a lot of patients and training a lot of other institutions. So there are a couple really cool chapters and stories in there if anyone is interested in reading more. And these are some of the references, just the original paper, some of the studies I mentioned, and the book recommendation. And if we have any time to discuss, we can do that now or move on to the next one.
Okay, great. Thank you so much, Alex and Leah. If anybody has any questions, feel free to throw them in the Q&A, or you can raise your hand and I can unmute you. I guess I had a question first off, kind of for Dr. Groves, about what has your training involved in terms of learning how to do these types of closures? We heard from Dr. Bowman last week about learning how to do this on a baby doll many years ago. So I would just love to hear more about what your experience has been.
Sure. I have a couple of slides that I can share actually. So let me see if I can do that
Sure.
now. Um, no, it may not let me. I'll figure this out as I go along, but okay. Well, so with regards to training, I think it's interesting, right? If you think of the MOMS trial, it's really only been in essence since the 1990s, 2010. And at the time, you mentioned the 3 centers, those are really the only prenatal centers that were offering prenatal surgery. I think also to go back historically, it's important to remember that prenatal surgery really consists of multiple different specialties and specialty teams, right? You have to have both a pediatric surgery team, a high-risk OB team. A lot of the counseling that's done for these patients is done in a multidisciplinary fashion. So really the development of that kind of center had really only been in a couple of different places at the time. And spina bifida was the first non-lethal disorder that was considered for prenatal repair because at the time prenatal surgery had such high risks. And I think what you highlighted were a couple of really interesting points. So just to go back on the idea of the second hit or hypothesis, which is really what drives kind of the ability for us to intervene on spina bifida. As the open neural tissue is exposed, that exposure to amniotic fluid over a period of time can lead to an ongoing CSF leak. And what we think is that that really drives the formation of both the hindbrain herniation or the Chiari-2 malformation, as well as potentially gunking up some of that area and impeding the CSF flow. Because of that, if we're able to intervene in a certain fashion, and this is what they showed with the animal studies, we think that by closing that and applying a watertight closure, we're able to stop that continual transmission of CSF fluid and hopefully then improve both the hindbrain herniation as well as hydrocephalus. I think what's really critical to take home from this trial, though, is that it's not a complete slam dunk, right? In the sense that historically rates of hydrocephalus at the time were probably as high as 80 or 90%. It's likely not that high in our current population because we are more tolerant of ventriculomegaly or extra fluid within the brain, especially for kids with myelomeningocele. But the rates of hydrocephalus theoretically were decreased by half. What that means, though, is that still 40% of infants require a shunt. And I think it's really important to manage expectations of these families that come in. That have done a lot of research, that are very motivated to do the intervention despite maternal risks, which you mentioned. And so for a lot of these families and patients, having a shunt or requiring a shunt can feel like a failure. What I like to remind them as well is that shunting is something where the initial shunt, if it takes place during the neonatal period, has a significantly higher risk to the patient. And if we can delay that shunt beyond several months or even 6 months, we can actually improve the rate of shunt malfunction or shunt failure. So even though patients are requiring shunting, up to 40% of patients, the majority of those infants are getting shunted outside of the immediate neonatal period. So I think there is a lot of benefit from that standpoint. The Chiari-2 malformation, which you mentioned as well, and the hindbrain herniation, I think is also really critical because almost uniformly, I would say 80 to 90% of these infants will have radiographic evidence of Chiari. However, it's only clinically symptomatic in about 10 to 15%. But those infants with a Chiari malformation have the highest rates of morbidity and mortality within the first year of life. So by improving hindbrain herniation, improving rates of shunting outside of the neonatal period, I think the MOMS trial really does show an improvement. What I was hoping to show with some of my slides, and I'm sorry, I'll try to come back to it, is that, there are, I think, I don't want to misspeak. I think there are about 25 or 26 centers throughout the US that provide fetal surgery because it does require a specialized multidisciplinary team. Both fetal repair, fetoscopic repair as well, utilize techniques that are really different than what we use in our training. And I myself didn't do a lot of fetoscopic repair or fetoscopic techniques until I was an attending, so well outside of my residency period. What's nice about the open myelomeningocele, or what's really transferable, is that the techniques that we use and the closure that we do is very similar to what we utilize from a postnatal standpoint. So the ability to use what we've done throughout our training and then put that in a really high intensity environment where time is of the essence. You know, we don't want to leave these women under general anesthesia for a prolonged period of time. Maternal morbidity is really important. So the length of that procedure and the length of the closure is really critical. And as a result, having the ability to take something that we've learned how to do from our residency standpoint and transfer that, I think, is one of the real benefits of open closure. You mentioned open versus fetoscopic as well, and it sounds like you've had some talks on that. I think there is some real evidence that shows that fetoscopic repair provides a very comparable repair to open myomeningeal repair, albeit from a more minimally invasive fashion. And so what that allows is that women can go through a more natural kind of childbirth process. In general, the risks associated with maternal risks are also lower than the open myomeningeal repair. But long-term data is really outstanding. And so we don't know from a tethering standpoint and a functionality standpoint what that means for a lot of our infants. In general, fetoscopic babies are about 5 to 7 years out.
Amazing. Thank you so much. We did have one question in the chat asking whether there are any factors besides the lack of training that might explain why only 17% of neurosurgeons recommended prenatal versus postnatal closure.
Well, because I think we still see that some children require shunts. And in addition to that, you know, the MOMS trial really it shows that there's improvement from a fetal standpoint, but you also have to remember that only about 20% of infants qualify or are eligible for prenatal repair. There's a significant amount of infants that don't meet criteria for various reasons. There are lots of families as well that from a family planning standpoint may not be eligible. Oftentimes young mothers who really want to have a large family, this may not be the best procedure because every time they have a pregnancy, they have a significant risk of uterine dehiscence or uterine complications that can lead to not only the baby's death, but also maternal death as well. And so while there weren't necessarily any maternal deaths associated with the MOMS trial, there have been associated maternal deaths with other prenatal type of closures or prenatal interventions. And so it really is a very targeted group of patients that we can offer this for, and it doesn't really generalize to all of babies with myomeningeal.
Okay, thank you so much. I think with that, we will move on to our next paper. So Collins and Laura, I will make you guys co-hosts so you can share your screen.
Fantastic, thank you. Well, hi everyone. I'm Collins Hart from Finland, and please note that it's 3 o'clock in the morning, so I had to come to the hospital conference room, and very nice. Well, thank you for the previous presentation, and it's very nice to meet you in this setting, Dr. Groves. And I will go ahead and share my screen. And one moment. Can you see my screen now?
We can, but we can, oh, there you go. Now you're in full screen.
Fantastic, yes. So basically, I go ahead and introduce myself first. I'm Collins Hart. I'm a former concert pianist, former national team athlete, 400 hurdles champion, and I'm currently a member of a Congress of Neurosurgeons as a medical student, and I'm a 3rd-year medical student in Europe. In Europe, we have a 6-year medical school program in comparison to the United States, and I'm currently studying in Romania, and I had a privilege to actually do research for Dr. Lipoma, a laboratory in neuroscience, and I was privileged to help a neurosurgeon during neurological operations. And Laura, would you like to introduce yourself?
Yeah, sure. Thanks for the opportunity, Collins. My name is Laura Fogem. I am from Windsor University School of Medicine. I've done some presentations with MSNTC, wonderful ones, and outside of that, I mostly do a lot of nonprofit. I'm a hopeful applicant for a 2023 cycle, and I'm a epilepsy seizure advocate, and I'm just looking forward to getting to this tonight. So thank you for having me on your panelists tonight.
Fantastic. Thank you for introduction, Laura. So I will go ahead and start. I beg your pardon?
Oh, no, go ahead. That's fine.
Yes, I will go ahead and start the abstract of the object. So basically, our research was on, if I can quickly say, Filum terminale lipomas, more likely imaging prevalence and natural history and conus position, and well, we do know that Filum terminale lipomas are being identified with increasing frequency due to the increasing utilization of MRI, unfortunately, and maybe associated with the tethered core syndrome. And we do know that Filum terminale lipomas are diagnosed incidentally, and that's very important, that they're diagnosed incidentally in patients without any symptoms of TCS, and the natural history of FTLs is not well defined. However, the quick review on Filum terminale lipomas basically is a type of limbosacral lipoma in which the fat is entirely with the Filum terminale and separate from the conus medullaris. So here we can see the lipoma and here as well. And just to have a quick review when exactly located, usually it's located here in the Filum terminale internum, and as we probably all know, lumbar puncture needle comes within between L3 and L4, and that's actually very common lipoma location as well. But usually it's more likely located at L1 level. And well, the methods, the clinical imaging records at a single institution over a 14-year interval were searched to identify patients with FTL. And more likely, the clinical records were reviewed for indication for imaging, presenting symptoms, and perceived need for surgery, and of course, clinical outcomes. A natural history analysis was performed using all patients with more than 6 months of clinical follow-up. And as we proceed, I can just conclude the results that we had a total of 436 patients with FTL were identified. And within these patients, we had 217 males and 219 females. We had 282 of patients were adults and 154 were children. Symptoms of TSS were present in 22 patients, and 52 patients underwent surgery for FTL, and the 64 patient had a low-lying conus, as we can see here. And of course, the 21 patient had a syrinx, and just a quick knowledge for syrinx is a fluid-filled cyst, as we can see here and here. And over time, this cyst can enlarge and damage spinal cord and cause pain, weakness, and stiffness. And 249 patients with a mean follow-up time of 3.5 years. And in the follow-up period, only one patient developed new symptoms. And just a quick overview of the conclusion. Filum terminale lipomas are a common incidental finding on spinal MRI, as I previously mentioned, and most patients present without associated symptoms. And of course, the untreated natural history is generally benign for asymptomatic patients. Now, just a quick review of our methods. We do know that after obtaining approval from the University of Michigan Institutional Review Board, medical records of all patients were reviewed between January 1 of 1997 to December 31st, 2011. The records of over 50,000 consecutive patients who underwent lumbar spinal MRI were searched with terms Filum or RAT query search engine, demographic information, including age, sex, presenting symptoms, the indication given for the initial MRI study, and if any surgical treatment was pursued, the surgical data, including choice of the surgery, and of course, treatment outcomes were collected. Imaging characteristics were evaluated, including verification of FTL, the location of the conus, presence of syrinx, and of course, presence of vertebral anomalies such as hemivertebrae. And patients with untreated FTLs who had clinical follow-up of 6 months or longer were evaluated to assess the natural history of the lesions. And of course, analyses were performed to evaluate the association of age, sex, initial imaging characteristics, and the clinical characteristic of symptoms, surgical intervention, a conus level presence of syrinx, and other imaging characteristics using the Fisher exact test or ANOVA testing. And of course, data were analyzed using SPSS and SAS. And I have to quickly mention that as far as the results are concerned, we had a percentage of a patient within each conus level in those presenting with symptoms compared with the patient presenting incidentally. As we can see, I did mention here that L1 is most likely location for this presentation, but we have here over 100% of the patients had no symptoms, but here we can see that as we approach this unit here, we can see that, for example, at L4, over 50% of the patients had symptoms. However, at the same time, over 50% of the patients in our cohort had no symptoms. So that's in conclusion. And also we can see from here that's here we have L1, and it's approximately 38 to 44%, which is a conus level in 282 adult patient with FTL. And here we have again L1, for example, for patients who are from 1 to 5 years, 6 to 11, or 12 to 17 years old. 37, approximately 51 or 36%, which is a conus level in 154 children with FTLs stratified by age group. And of course, here we have L1 and L2. I did mark here with the red color, 27 and 30%. And it's a conus level in age-matched children without FTL stratified by age group. And just in conclusion, I would say that low conus position was found more frequently in children with FTL than in adults. And spinal syrinx was also found more frequently in children. And here's the location of L1 and L2, as I showed in the previous picture. And just the results. We have to, just a moment, I move those notifications from here. Yes, so I'm so sorry. So left on the left side, as you can see here, we have a conus level percentage for two populations, adult patient with lipomas and compared with the normal control adult patient. And as I said previously, L1 and L2, we can see that even though the control is a high volume, we do have a over 23, almost 23% of FTL here. And on the right side of the picture, we can see this percentage of patient within each conus level for two population, children with lipomas and age and sex match control pediatric patients. And we do, we can see here again that L1 have control for 45%. However, we have increased level of FTL, almost close to 43 patients in that result there. So I just quickly want to summarize the results that's presenting symptoms in 22 patients with FTL. That's included 7 adults and 15 children. Usually had a urology complaint, symptoms of bowel abnormality, leg pain, back pain, motor gait disturbance, sensory complaints, and orthopedic abnormality. And most patients had more one presenting symptoms. And I think now is the turn to Laura to continue.
All right. Thank you, Collins, for a wonderful presentation. Thank you, Nikki. Thank you, Dr. Groves. So my part of the presentation is mostly discussion and maybe interpreting a bit of the data. So first of all, I'd like to say that the advent of diagnostic imaging has definitely led to more cases or more identification of FTLs. Most of the ones that were identified, unfortunately, or fortunately, are asymptomatic. But for the ones that were asymptomatic, the distribution went from the most symptomatic presentation being urological symptoms, which accounted for 59%, bowel abnormalities that accounted for 23%, leg pain, 32%, back pain, 32%, motor, gait disturbances, 27%, sensory complaints, 14%, and orthopedic abnormalities accounted for 9%. So most FTLs in adults are incidental findings, and they typically require no intervention. For the ones that are asymptomatic, however, the fat is within the phylum, as Colin mentioned earlier, and these ones were the ones that had the fat or the lipoma closer to the conuses. So the level of the conus, unfortunately, as well as the thickness of the phylum, has in the study has no correlation with it being symptomatic versus not being symptomatic. Initial studies excluded pediatric patients who had conuses below L2, and that is later on would count as a weakness towards the study. And a normal conus level is a negative predictor for symptoms in the study. So in conclusion, conuses at level 1, the number of adults in the study exhibited low conuses position in the FTLs group and producing statistical significance and with a usual or an unusual difference from the adult control group. Whereas in children, there is not as much as statistical significance because the distribution is skewed. One of them being the reason that pediatric populations with conuses below L2 were excluded. So that contributed grossly to the discrepancy or the skewness of the data. So then another reason would be the fact that children, since most of the cases are incidental findings, the number of things that would cause a child to get an MRI versus an adult to get an MRI, it's varying. So there are different reasons for which they'll get a need or get an MRI. So because of that, a lot of these diagnoses can be missed only because they are visiting or getting diagnostic MRIs for different reasons. So if we're going statistically by it being incidental findings. Also, more symptomatic children were used for the study versus asymptomatic students, and adults and children undergo, again, like they undergo imaging for different reasons, so you really cannot tell. And those FTLs with FTL conus at a high positions with advancing ages proved to have a likelier probability of being symptomatic. So in a mean follow-up of 3.5 years, only one person developed new onset symptoms or worsening symptoms between the ages of 12 to 17 years. And in a 1.5 year study follow-up, no adult or child had new symptoms or worsening of symptoms. So in comparison with tethered cord syndrome, back pain, urologic symptoms, and neurologic symptoms were the most common findings in with children versus adults. And so the management, of course, is different. So in the study, 5 patients with FTLs possibly had in their tethered cord syndromes with normal positioned conuses. So in going through the study, my question there would have been how many had abnormally positioned cones, but were with existing FTL and TCS, or tethered cord syndrome. That was not accounted for. Also, we see here in the study that surgical management or prophylactic surgery has a good outcome for children. So next thing is weaknesses. It's part of the conclusion. So the study is limited to several factors, one of them being selection bias. new prevalence is included in the study in the sense that the FTOs likely only report MRIs, incidental findings. So there's really no way to sum up prevalence in here. And then there's also the conclusions are drawn from medical records. So there's also a diagnostic clinician bias. So the clinician already knows that this condition exists. And so that poses a bias in the study. Also, children who receive prophylactic surgery had no symptoms. So there's no way to measure a control group or to measure what the outcome was, subsequently for them. Did they later on develop symptoms? And if so, what were they compared to the ones that, which ones were more from the bucket list of symptoms that were early on enumerated? So part of the weakness of the study was the existence of comorbidities. So such as myelomeningocele, lipomyelomeningocele, Conus lipomas, dermasinus tract, complete sacral agenesis were not included. So that too could be part of the weakness in the study. And last but not least, unfortunately, in labeling the caudal end, it's a rectangular type vertebrae, and also there's no way to really account for persons, child or adult, with more or fewer lumbar vertebrae. So there's that bit of a discrepancy there that really we cannot account for. So those are some of the things that stood out for me in the article, and as far as drafting out the presentations. I'm happy to take any questions. Thank you.
Well, thank you, Laura. Thank you, Laura, for your wonderful parts. And yes, if anyone have any question, please ask us. Let me go ahead and stop sharing the screen. Yes.
Thank you guys so much. We're actually going to hop right into the next paper. And then if we have time at the end, we'll have questions for both. I just want to be really respectful of everyone's time because we only have like 5 minutes left till the hour.
Okay, so, that makes sense.
But thank you so much. I'm going to go ahead and
worries.
share my screen for the last one. All right, can everybody see that?
Yes.
Okay, perfect, thank you. All right, so our last presentation here is on the use of MRI to detect occult spinal dysraphism in infants. I'm gonna kind of brush past some of the intro stuff that we've already had talked about in some of the other presentations. But for the sake of this study, they defined occult spinal dysraphism as any anatomical abnormalities of the spine that attach the cord to dura, bone, and soft tissue. And it's been linked to a variety of cutaneous markers and other anomalies, including anorectal malformations, vertebral anomalies, etc., that I think most of us at this point are familiar with from some of the other lectures we've had previously. And so for the sake of this paper, that's how they defined it, because other studies have defined occult spinal dysraphism a little bit differently. The gold standard for occult spinal dysraphism diagnosis is considered MRI, but ultrasound is often used because it involves fewer logistical challenges. MRI requires these infants to be sedated, and whereas ultrasound does not. However, you don't get as much granularity in your imaging with ultrasound. And as the bone ossifies, as the children age, it becomes harder to identify these things with ultrasound. However, there is some disagreement among neurosurgeons regarding doing some early diagnosis and prophylactic detethering surgery, particularly in patients that are asymptomatic. But surveys that were done in the 2000s showed a lack of consensus about the type of imaging, ultrasound versus MRI, in cases where you just have a simple dimple over the lumbar spine or above the coccyx or the gluteal folds, or in other cases with the cutaneous manifestations like hemangioma or deviated gluteal fold. And other studies have looked at how well ultrasound can screen infants for occult spinal dysraphism, but high resolution MRI hasn't been studied as much. So that was the purpose of this study. They did a retrospective review of all non-contrast lumbar MRI studies that were performed in a 6-year period. And they had some, I won't go over the specific exclusion criteria, but for the inclusion criteria, they defined occult spinal dysraphism as a low-lying conus fibrolipoma of the filum terminale of any size, a thickened filum terminale without lipoma, lipomeningocele or lipomyelomeningocele, or a dural sinus tract, myelocystocele, or a split cord malformation. So all of those were included. And the other thing that they measured was in patients that had a sacral dimple, they measured the distance from the tip of the coccyx to the dimple. The dimple you can see with the arrowhead there. They used actually, which I thought was kind of interesting, vitamin E capsules so that they could mark where the dimple was in the MRI imaging. I didn't know that was something that was done. And they looked at this because previous studies have evaluated the position of a sacral dimple as a predictor for occult spinal dysraphism. So they wanted to see if that finding would show up here as well. So getting into the results, they had 522 study participants, 46% female, 54% male. The average age when they did the imaging was 6.2 months. And overall, 23.4% of their study cohort had an occult spinal dysraphism, according to that definition I went over earlier. As far as indications for imaging, the most common indication was a sacral dimple, just in isolation without any other manifestations. But there were various cutaneous findings that prompted imaging, like a symmetrical or asymmetrical deviated gluteal cleft. Hemangioma was another common one. And then there were about 6% of patients that had other cutaneous stigmata other than the ones listed, like a dysplastic skin, hairy patch, skin tag, etc. And all of those are grouped under that second to last line with other isolated cutaneous stigmata. And about 18% had more than one of the cutaneous markers that are listed there. So as I said before, about 23% of this cohort had occult spinal dysraphism, and about 81% of those had filar abnormalities. And the most common tethering abnormality found on imaging was a fatty filum terminale with a normal conus level, followed by a low-lying conus alone. And that group that I mentioned that had isolated cutaneous stigmata had the highest percentage of occult spinal dysraphism at 55%. And those patients also had the highest proportion of complex occult spinal dysraphism, meaning lipomyelomeningocele and dural sinus tract. And then the second highest rate was among the patients that had congenital anomalies, followed by patients that had multiple cutaneous markers. And all of the patients that had lipomyelomeningocele, dural sinus tract, and lipomeningocele underwent tethering surgery. And about 61% of patients that had filar abnormalities underwent detethering surgery. The least likely to undergo an operation were those that had an isolated low-lying conus, with only 41% of that group having detethering surgery. And then lastly, they looked at the association between dimple location and occult spinal dysraphism, and they actually didn't really find any significant findings. So the average dimple position in patients with OSD was about 15 millimeters above the coccyx, and those without OSD, it was about 12.2, but that difference was not significant. And they broke those out into 3 different groups, depending on the location relative to the coccyx, and they didn't find any significant p-values there. But they did find that they had a few outliers with dimples that were more than 40 millimeters above the coccyx. And amongst those patients, about 62% had tethering lesions. So in their study, they found that this wasn't necessarily a good predictor of occult spinal dysraphism, but they also acknowledged that there's a lot of factors such as dimple size and the shape and various things that they couldn't look at with these MRI images. So that there could really be more to explore there. I'm gonna, for the sake of time, they had a bunch of different cases or specific cases that were included in their study that they went over. But for the sake of time, I'm not gonna go over those. So if anyone's interested, I'd highly recommend looking at this paper because there's a lot of good imaging in there that you might find useful. But with that, I am gonna pass it off to Stephanie to do the rest of the discussion.
Thank you, Nikki. So I'm so sorry I can turn my camera now. I think I need the permission of the host. I am Nicole Fuentes. I'm a medical student from Bolivia. I'm very glad to be here and sharing this paper with you. So now we're going to talk about the efficacy of ultrasonography. In this study, there were identified 61 infants that had lumbar ultrasonography prior to their MRI imaging studies, and 3 of them were excluded because of their inconclusive US reports that showed ossification of posterior spinal elements. So this is related with the age of the patients that we are going to analyze further on. And there were 58 patients that were analyzed in this study. So 38 of them had a report that really showed a concerning of OSD, and 20 patients did not show evidence of OSD. From that 20 patients, 11 of them had filar cyst, and 9 of them, they had a normal report interpretation. From these 20 patients, 16 patients had normal MRI studies, and 4 of them had false negative findings. So these patients also had fibro lipoma, final terminale with normal position on the conus medullaris. So in the next one, we're going to see also the discussion that we are going to doing the comparison of the another studies. In the screening process, the more highlight yield characteristic is that the modern high resolution MRI was optimized to detect this OSD. So it was able to capture the more slightest anatomic differences. So it showed like a higher rate in the 23% of the patients that the MR imaging revealed the OSD. It had an improved control resolution of MRI that detected the slightest anatomic changes. So now we're going to compare the US versus the MRI imaging. So the first one we have to analyze is the cost, and the next one, the sedation. So ultrasonography, you can do it on a patient as feasible as possible, the early months that they have lived. And in MRI, you have to analyze the age. And the study showed that they had like a mean age that was from 6 and 2 months. So the age, it parts from an observation of adipose tissue within the intramedullary lipomas were associated with dysraphism, and it has reported that it enlarged with an increase in the body adipose tissue. So in the next, we are going to see, in the next slide, please, we're going to see this table that was from the studies that were consisted in this report. The first one, Ben, Sierra et al, and Cher et al, they had like an age months of mean that the patients were started from 1 month and 1.4 months, and the next one was in 1.2 months. But this study had a mean age of 6.2 months. So it improves the development of lumbar skin in early months of life, allow a clear assessment of dimples. And the latter age of the patients for MRI allows a better toleration of sedation. That is another thing that the US does not have, and better appreciation of anatomy. So the US is not possible to do or to perform after the ossification of the posterior spinal elements that it normally occurs within the 6 months of the patients. So in the next one, we're going to see another chart of the studies that they had done. So the first two studies, we have the filtering definition that is like the one from the study that we are presenting. In the next one, we are going to see the next discussion that is related to the dimples. So it is present in 2 through 4% of neonates. And in the 20% of the patients that were studied with isolated dimple, they had OSD, but it did not show any difference with low implantation dimples or higher dimples. So in the intergluteal dimples, there was a study performed by Harada, which showed that 16% of 84 patients had this fibro lipoma final, and the deep dimples were associated with OSD. So there was another study with show that 109 patients with dimples within gluteal crease screened with ultrasonography that was performed by Ben and Sierra. And the next one study that showed that 643 patients were screened by ultrasonography studies, and the patients that showed dimples just in 0.8% with OSD, they required surgery. So in the next one, we are going to see that there has been some attempts to show some predictor factors for OSD, that maybe they included deeper dimples or maybe wider dimples or dimples that were located over the sacrum, but there isn't still a correlation between OSD and the dimple height. Okay, so in the prevalence and natural history, many of the OSD lesions identified were subtle and unlikely to be identified without this improvement of the MRI sequences that were optimized for this purpose. So the limitations of this study show that it is just a retrospective study, but very complete, but it did not allow to assess some other factors like the cutaneous stigma of the patients and the depth and width of the dimples that were imaged. So in the conclusions, we can say that the prevalence of OSD has been identified with higher resolution MRI screening and is significantly higher than reported with the ultrasonography screening that were performed in patients with sacral dimples. So in the majority of OSD lesions, there were these fibrolipoma, Filum terminale, and low conus, and higher were identified by prevalence support, and they have to have a less aggressive surgical approach. So that is it for our paper, and I think it was an important and interesting paper, and thank you for your attention, and we are happy to receive any questions.
So maybe just to tie things up, I have a couple of things that I just wanted to share. That's a common theme between both of the papers that were just discussed. I think the most important thing to remember is that tethered cord, or having a tethered cord, or having spina bifida occulta does not necessarily mean that patients have tethered cord syndrome. And what's key about that is that, as the final paper suggests as well, you know, there can be a significant prevalence, up to 24%, that's seen on MRI scans, but the vast majority of those infants are asymptomatic. And in fact, when we recommend surgery, oftentimes we're doing so in asymptomatic patients with the idea that we are potentially preventing symptoms. That can be really hard, and there's a lot of controversy even within the pediatric neurosurgery community as to what the appropriate kind of clinical action is. And so let me see if I can make this work. I just wanted to show, I think this was referenced in one of the papers as well, from the standpoint that there's a lot of controversy, even as recently as only a couple of decades ago. And what we did was kind of look at all of the pediatric neurosurgeons that were at a pediatric meeting. In general, there are about maybe 200 within the US. And so the idea was, you know, in which case would we recommend surgery versus observation? And uniformly, in patients who have a fatty filum or who have a low cord position, the majority of the neurosurgeons would offer surgery or recommend surgery. There's a little bit more, you know, equipoise when you talk about patients with fatty filum who have a normal cord position, but then look at patients who, for example, might present with tethering type of symptoms like potentially back pain or maybe urological issues, who have a normal filum and a normal cord position. So essentially no findings on MRI. Or even a normal filum and a normal cord, but maybe have a syrinx, which sometimes can indicate potentially tension on the spinal cord. In those cases, right, there's a lot more disparity between the neurosurgeons in terms of what they would recommend. So I just want to use that to highlight the fact that there's a lot of inconsistency in tethered cord. A lot of that comes from how we have defined it over the years. And so when we read papers with regards to spina bifida occulta, I really want to highlight and emphasize that you have to read everything with a grain of salt and kind of take into consideration what they're talking about. Both papers indicate that potentially for complex lipomyelomyingoceles or complex dysraphism type symptoms, that those patients uniformly would go on to require surgery or have surgery. There's less debate about that. What we really struggle with are these kids that present with essentially no findings, who have a relatively normal looking cord and maybe just a tiny bit of fat. In general, the Michigan group kind of indicated that the majority of these infants would not become symptomatic, and so that the intervention that we would offer with regards to surgery and untethering might be higher with the risk of complication or the potential risk of retethering in the future because of scar tissue versus the actual natural history, which in fact is probably quite benign. So those are just kind of, I think, the big picture take-home points with regards to spina bifida occulta. But that was a nice review to show that really it's probably a lot more prevalent than we think, but yet we don't really understand or know, what the clinical need is to intervene.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.